once again today on the fourth Thursday of the month to know more about what has happened in the recent past in myeloma. And we have a galaxy of guests from the national and the international forum. And our guest, in fact, from Bangladesh will be joining us and sharing his experience as well. Without much ado, I would request Dr. Harihanan, who will be moderating the Journal Club discussion from the national perspective. I would request him to introduce Dr. Annie and start away with the Journal Club presentation.
Yeah, thank you, Varun, and welcome all for our the next session of our Image Journal Club. And we as people who treat myeloma are in some good times, I would say, because right from the beginning, myeloma has always given us hope to be able to do better. Right from the time from melphalan, always each milestone in newer modalities of treatment has given that much more in terms of improvement in survival in myeloma, where we look at a median survival of at least 10 years these days. Right from the time from melphalan to transplant to IMiDs to bortezomib and to the monoclonal antibodies and now the cellular therapy with CAR T cells, we have had so much of improvement in the disease-free survival, progression-free survival in myeloma, prolonging survival significantly. But the challenges still remain with treating myeloma, especially the high-risk cytogenetic risk groups and also the steeper decline in the survival rates once the patient relapses. And today, we are having answers to that too with the evolving therapy in the form of CAR T cell therapy for myeloma, with various CAR T cells coming into the picture with well-structured phase 1, phase 2 studies, and now phase 3 studies, demonstrating consistently an improvement in survival and improvement in responses rate, and more so improvement in responses rate even in terms of achieving MRD negative status, which is now something that is considered as an endpoint for outcomes in myeloma. So today we are gathered here to discuss one of the landmark studies, which was a phase 3 study, which is looking at cilta-cel, which is an anti-BCMA CAR, a phase 3 study comparing it with the standard arm treatment, wherein patients were refractory to lenalidomide therapy. And the results of the study was published in the New England Journal. And today's choice of the article is to discuss this particular study, which will be presented by my colleague, Dr. Annie Ba, who's the assistant professor at the St. John's Medical College and actively involved in myeloma treatment at our center. So without much ado, we can go in for the discussion after the study. And thank you, Nikhil, to be part of this program. And I hand it over to Annie to initiate the discussion on this particular journal club, which we have selected for discussion today.
Harry, if I may interrupt for a second.
Yes.
You started with the introduction saying that so much has changed today. I thought you were going to first mention about the Chandrayaan landing more than.
Yes.
But no, it's a wonderful time for many reasons, including for myeloma. So, Annie, go ahead.
Yes, thank you.
Thank you so much, sir. Thank you for this opportunity. And I may share my screen. Are my slides visible?
Yes, please.
Yeah.
So welcome to the Journal Club for 24th of August. Today, we'll be discussing, as Hari sir rightly mentions, cilta-cel or standard of care in lenalidomide refractory multiple myeloma. So if we look at the treatment landscape in early relapsed refractory multiple myeloma, what do we have? Current options comprise of IMiD, proteasome inhibitors, corticosteroids, antibodies, alkylating agents. and others. So we use this in the front line as well as in early relapse refractory setting. But when the permutation combination doesn't work for our patients, we have to think of new treatment modalities by which we can help in the cell inhibition as evident in the picture. And that's where our future direction is heading to. Why we have the BiTE, we have the antibody drug conjugates, and our topic of interest today, CAR T cells targeting BCMA. So we have become wiser in terms of CAR T cell therapy, as we can see in the slide, that we have a first generation, second generation, and you see that the signaling domain that is there in the intracellular part is becoming, has more of addition of co-stimulatory domain, and the addition of the second co-stimulatory domain comprises the third generation, and so on for the fourth generation, where the cytokine inducer is added on. Our topic of interest today is the second generation CAR T cell, the cilta-captogene autoleucel, where we see it comprises of an ectodomain, which has the antigen recognition domain, having the two heavy chains linked with a flexible linker along with a spacer, and then the transmembrane domain, and the innermost part, that is the endodomain, which takes care of the T cell activation. And then the second, as the second generation CAR T, it has, along with the CD3 zeta, it has 4-1BB, which helps in a better T cell activation. So how is the mechanism? How does it work? By inflammation and destruction, by producing pro-inflammatory cytokines, recruiting more of immune cells, and eventually cytolysis by apoptosis using the perforin granzyme enzyme and the fast-facile axis. So where do we stand today? We have, as Hari sir rightly mentioned, we have sequential trials that have evaluated the efficacy of CAR T. And here in this table, we see CARTitude 1B2, which Nikhil sir just presented in EHA 2 2023, where a heavily treated population with a median line of 6 lines of therapy had a marvelous progression-free survival of 35 months. And also, and to notice, around 88% were triple drug refractory patients, and overall survival was not reached. In the second CARTitude 2, we had a multi-cohort phase 2 study where again they analyzed different types of patients, and there too, if we see the overall response rate, it's commendable in a heavily treated population. The Karma one, where they study, where again the BCMA CAR T was studied, where again a heavily treated population was taken, but here the ID cell, the other CAR T was analyzed, and that too showed a benefit of overall response rate close to the tune of 75%. And the recently we had the Karma 3, which was just published, that was a phase 3 trial, ID cell versus standard of care. That too showed a progression-free survival of 13.4 months compared to just 4.5 months in a standard of care. So coming to our topic today, cilta-cel or standard of care in lenalidomide refractory multiple myeloma. We all have been using lenalidomide in treatment naive as well as refractory patients, and it has become a very important part of our treatment protocol. But when patients become lenalidomide refractory, studies have shown that the median PFS in these patients is less than 1 year. So this is definitely a very clear unmet need, and we are desperately in need of new effective therapies. This is where the CAR T cell has come to our rescue, and the trials that we discussed earlier have shown brilliant response in terms of heavily treated population, and as evident in CARTitude 1 study, where we had a PFS benefit of the median PFS of 35 months. So here in this trial, we'll be discussing the efficacy and safety results of cilta-cel versus the standard of care from the interim analysis. So this was a randomized open label phase 3 study where patients with multiple myeloma with a PS of 0 to 1, having 1 to 3 prior lines of therapy, including a proteasome inhibitor, immunomodulator, and lenalidomide refractory were stratified. After having a bridging therapy, the infusion was given, and then we had the safety and efficacy data collected. And the standard of care that was here taken was a PVD regimen or a DPD regimen. The primary endpoint being the PFS, with our secondary endpoints, the CR rates, the overall response rates, and a very important molecular test that we do right now in myeloma, MRD negativity. This analysis was taken after approximately 16 months of follow-up. So 208 patients were randomized to the SITA arm, where single dose of the infusion was given after the physician's choice of bridging therapy. And as we see here, the standard arm had the PVD and the POM DARA DEXA therapy. So if you look at the baseline characteristics here, it was well matched in terms of age, performance status. To note here is the median lines of therapy here is 2 in both the things. They have taken more than 1 to 3 lines of therapy in this study. And if you look at the cytogenetic high-risk profile, we see 60% of them had a high-risk profile with gain or amplification of 1Q, and around 45% of our patients, and are heavily pre-treated triple class exposed, with the triple class refractory around 15%. So when we look at the progression-free survival, that was the first, that was the primary endpoint. We see the graphs here, and here we see a median PFS in the cilta-cel group that was not reached. It is widely separated here and compared to just about 12 months in the other arm. So here we see that the response rates and the PFS rate at 1 year was definitely significant with the cilta-cel group compared to the standard of care group. Now, if you look at the subgroup analysis, we see that the PFS benefit has been consistent across all the patients group, all the patient subgroups, including irrespective of the number of lines of therapy, the ISS staging, the prior drug exposure, or the cytogenetic makeup of the patient, and the refractory status. So every subgroup had benefit with the infusion of the cilta-cel therapy. Now, if we look at the secondary endpoints, we see how much the difference comes in here. The CR rates is 73% compared to just around 22% in the standard of care arm. And the duration of response is, we can see it's a durable response. It's not reached in the cilta-cel group compared to 16 months in the standard of care group. And to note here is the MRD negativity status in the intention to treat population, 60% versus 15%. And if we see the treatment responses again in just the 176 patients that received cilta-cel, we see definitely a very good response of overall response rate of around 85% of CR rates in these patients, and also a MRD negativity status in 70 patients. If we have to compare the efficacy results that were shown in CARTITUDE-1, we see a slightly higher 12-month PFS and the CR rates compared to what we saw in a heavily treated population as was taken in the CARTITUDE-1 study. This is where everyone questions what were the adverse events with the CAR T-cell therapy. So in this study, we see that serious adverse effects were almost comparable, and 95% were hematological toxicities as is anticipated. And the infection rates were 62% in the cilta-cel group compared to 71. So there's not much of difference with the standard therapy that is given. And the CR rates, the cytokine release syndrome, this is what everyone asks. We see here that it's just 1% grade 3, grade 4 toxicity seen in these patients. And the neurotoxicity too was 20% any grade and just 3% in as seen in as the grade 3-4 toxicities. And it was resolved with a median of 8 days. The neurotoxicity is resolved between 8 to 4 days, whereas the CRS around 134. There were no fatal neurotoxicities, and the severity of the CRS, ICANS, and the hematological were comparatively lower. So what was concluded from this study was cilta-cel demonstrated superior PFS compared with standard of care in lenalidomide refractory multiple myeloma, where we see median PFS not reached versus 12 months, and the PFS benefit was seen across all the patient subgroups. And also in terms of the overall response rate, that was a secondary endpoint that we see a considerable difference in the CR rate, 72 versus 22%, and also the MRT negativity state, 60 versus 22%. And about the safety parameters that we are concerned about, the incidence of grade 3, grade 4 toxicities were comparable. In fact, lower incidence was seen. Hence, cilta-cel definitely has the potential to be the new standard of care for patients with lenalidomide refractory multiple myeloma after first relapse. Thank you.
Thank you. Thank you, Annie, for that discussion. And just to set into motion the discussion regarding, and I would invite Dr. Munshi to take it forward. But overwhelmingly, we see that the CAR T-cell therapy is a winner. And more importantly, the positives that I see in most and almost all the studies is the responses that one achieves irrespective of the cytogenetic risk profile, the responses that we achieve irrespective of the number of cycles, number of regimens that the patients have received and failed, and also the depth of responses which are durable. And can we say that it is snapping at the heels of getting into frontline therapy for myeloma? So I leave it at that, and I would invite Professor Munshi to discuss and throw his views on this trial and the future of CAR T cells, and also answer the question whether it's snapping at the heels and replacing transplant.
Of course. And thank you, Hari, and really nice presentation, Annie, about this paper. And one of the reasons I think this is timely is because it is raising very interesting issues. So your conclusion is absolutely correct about CAR T cell, its incredible responses, its extending PFS. If we look at CARTITUDE-1 or KarMMa-1, it is even in late stage, it has an incredible response, 3+ years, etc. So there is no question, Hari, that it is really impacting or beginning to impact how we treat myeloma at a very basic level or at a fundamental level. Also, some of these treatments are increasing. There were 2 more drugs approved in US in last 2 weeks. Since your meeting a month ago to now, we have 2 more new bispecific. One is elrantinumab, which is BCMA, but the second one is talquetamab against GPRC5D. So this immunotherapy and bispecific and CAR T can be, in some ways, for discussion purpose, be put in one basket because they are in some ways adaptive transferrin or adaptive stimulation of T cells. And that's why we see incredible responses. And we could have a very interesting discussion some other day on that issue. But if we talk about this paper, there are a few things to notice. So one thing is the response rate. Response rate here is around 82, 83, 84%. And what it highlights is difference between responses here versus responses in CARTITUDE-1, 98% response rate. And we could argue, well, 80 or 90, what's the difference? But there is a difference. Because why do we think between the 2 CAR T cell, 181% response, other 98 is better? There is a difference. So when you are beginning to get to a real life scenario, you would end up seeing a little bit different responses. And so this is not truly a real life scenario. This is still a very much controlled experiment, but still it is done in a more broader setting. CARTITUDE-1 was done, and same way KARMA-1 was done in a very select centers which knew what to do, how to handle CAR-T patients. And now this is becoming more broader. So we're beginning to see more real life thing. But a critical component would be what one of your slide I think showed, was the comparison between CARTITUDE-1 responses, comparison between CARTITUDE-4 responses. CARTITUDE-1 is 6-line treatment. CARTITUDE-4 is 1 to 3, but median of 2 lines treatment. So median 6 versus median 2. And if you look at responses, and I wouldn't compare 2 different studies head to head, but at the best, they're identical. At the worst, CARTITUDE-1 is a 6-line is superior response than CARTITUDE-4. So what does it mean? Is it treating early a good idea? And I don't even want to imply that it's not a good idea, because that's not the true answer. But the point is that 6 versus second line gives us very similar results as far as response is concerned. The second component is PFS. Because one could say, well, responses are variable when you do smaller study. This is not small study. This is 200 plus patient study. But still, it is not a 1,000 patient study. And we're treated in Europe, treated in other countries outside Europe. And maybe they're still not as used to doing it. And I don't want to imply they don't know how to use it, but there are always a learning curve. But still, I think then we go to PFS. Yes, PFS is, if you put head-to-head curve, and I have a slide somewhere where CARTITUDE-1 and CARTITUDE-4 results are superimposed, and it still does not come out as well. There's a big difference when I'm doing early. So the second point would be, and sort of a beginning of a discussion here and also in other forum is treating early a right thing to do? Or in one of the discussions, the argument was, well, maybe we should wait till 6th line and then give it as a 6th line and still get the same benefit. So if you take PFS 2, 3, 4, 5, maybe they would be better. Again, so the question is that CARTITUDE-4 clearly shows super high responses in 80+% in second line. That PFS is very exciting. The median has not been reached, and it's clearly superior compared to the control arm. But it does raise an question, where would it be utilized the best? And there may be patient population where we may want to delay it or not, versus patient population where we want to do early. My personal guess and bias is based on this and many other data that I think we are going to begin to do it early, but just by itself is not going to be adequate. Because in many other studies, I think PVD was not a fixed study. It was patients' continued treatment. Versus here, one treatment and done. So it's not the best comparison, etc. So I think the second point comes out is that the way I would say is that how do we sequence the immunotherapeutic treatment? One treatment is not adequate, and I think we need to have some maintenance strategy to even make it better. So these unbelievable responses we see with CAR-T, and similarly less with bispecific, needs to be sustained. And even though the CARTITUDE-1 update showed 36 months of PFS at 6th line, I think we can still do better. So that's a second point. And then final point would be, we still have to keep in mind the neurotoxicity. They were around, and you have to correct me for exact number, but they were around 12 to 14% of patients who had cranial nerve palsy, and we still don't know why. But is it part of the broader neurotoxicity that we see with CAR T cell treatment targeting BCMA? They were reversible, they were not of a major, they were not life-threatening, but we still have to keep a good eye on it to prevent it. So there are many positives of study, and I can go on. I'm going to stop and see if there are questions. There are many positives. It clearly says that compared to standard of care, which in this case was PVD or DARA-PD, the bispecifics are super impressively better for PFS. We'll see what the OS ends up being eventually, but they provide really clearly very good benefit.
Thank you. Nikhil, I was just wanting to take up the thing. What about wanting to utilize it in specific cytogenetic risk group? Because it doesn't seem to, cytogenetic risk groups don't seem to have an impact. And for example, when you have a 1Q amp, none of the treatment really works, including a transplant or a tandem transplant. It still has its own independent prognostic effect. But we see that over here, the cytogenetic, it is irrespective of cytogenetic, it does produce an impact. So are we going to pick and choose the people whom we want to treat earlier than later with CAR T cells?
Yeah, so I think that might all boil down to, Hari, are we getting MRD negativity or not? So any of the risk stratification criteria we use, and in fact, there was a recent, and maybe we'll talk about it at the next time, but recent sort of consensus meeting, around 60 people were there, to redefine the risk. And so not all 1Q, and the reason I remember to mention this, is not all 1Q are high risk. In fact, 1Q by itself is going to be considered high risk. We'll have a publication coming out in next month or so with consensus from everybody. It's in the first lap is just being done. But the point that is going to be that not all 1Q are bad. 1Q with the 14 related translocation, or if there's a biallelic 1Q, it will be bad. So I think there were 40% or so 1Q in this study, 43% if I remember right. Half of them are not really high risk. The other may be high risk because they are with something else or they're biallelic. Now at this point, at this stage, I think getting MRD negativity is going to be the key starting out. Your question will require a little bit longer time to decide whether the true high risk I will give by a CAR T upfront and the rest I would do later or not, and is that giving me the best or similar outcome? We don't know that, but getting MRD negativity is going to be our endpoint for now, and if we don't get it with whatever else we are doing, I think I would have no significant issue utilizing CAR T, except in the current approval in the real life, at least in the United States, and most of the even more so in Europe, we cannot utilize early anyway. So except for study, we are not going to be able to use it. The first time we use it, we will use it in everybody, because when they relapse three or four times, they all are functionally, you could say, high risk, and we need to do the best. But in a scenario when it will be available, even in newly diagnosed patients, the question will come transplant versus no transplant. But because it is likely to replace transplant, practically speaking, and we can use it in older patient, I think we probably would not withhold it from patients who are not high risk. Probably everybody will end up getting it in the beginning till we really define where we do not need it.
So that again brings me to your own paper, where you have demonstrated increased mutation burden in patients who are receiving stem cell transplant with conditioning with melphalan. So
yeah,
is that really a concern?
Yeah, so it's an interesting paper. That was another paper that we were going to touch base today.
Yes.
And so if you would like me to comment on that, I'll mention this. So what we observed, and it was an interesting study, and that came out of the determination study, which was published in New England Journal, and I think it was discussed in this journal club few months ago. So these were the patients. Actually, the samples were not from determination study. It was from another New England paper, which was our French collaboration. And there was Michel et al.'s New England paper 3 or 4 years ago. Similar concept, exactly identical concept, except maintenance difference between the two studies. But to your point, what we did in this study was had myeloma cells at diagnosis, and then myeloma cells purified at the time of relapse. And we did the whole genome sequence on both to see what happens to the genome when patients relapse. Half of the patients had relapse following transplant because there was a randomization, and half had progressed without transplant. So the very good question was that when we give such a high dose of DNA damaging agent like melphalan, what happens, the hypothesis was that there will be more mutation, and that's what we found. So that's good news. It followed our hypothesis. What happens subsequently, and it is in the paper, is that what does increased mutation mean? Intuitively, we all, you and me both included, would think that increased mutation means bad myeloma. That is going to be aggressive, it will be progressive, patients will die early, will be more resistant. And we did not find that. And believe me, we have looked at all our friends across the globe to see if anybody had study and data that can confirm that post-transplant myeloma is a more aggressive myeloma. And we have looked and could not find it. If it was there, we would have put it in the paper because it will actually go above blood where we publish eventually. So why is that? Why is this high mutation burden myeloma not so bad? And so one of the last figure in that paper is a more hypothesis generating figure. So what we looked at and identified was that when patients have more mutations, they also have more neoantigen. So post-transplant myeloma relapse has significantly higher neoantigen burden than without transplant. What it might mean indirectly is that it is more immunogenic and that the immunotherapy we use might be more effective. Again, these are all hypotheses. We don't have clear proof, but the figure is there which shows more neoantigen post-transplant than without transplant. And so you could argue maybe we should do transplant, get more neoantigen, it's more immunogenic, and then immunotherapy would work better. So I think that study, although it's quite well done and shows very clearly what we see, does not answer the question whether transplant is good or bad. Does it answer your question?
Oh, yes. I mean, I mean, your explanation is really. I mean, it's not something that I would imagine. That, I mean, intuitively you would think that it's going to be a poor risk disease. So that was why my question came up. Yeah.
And we looked all across, and all the European groups and in the US, the studies, none clearly shows yet, in a true fashion, that post-transplant myeloma is an aggressive myeloma.
Yes.
So, okay.
Yeah, Doctor.
I think so.
Pankaj, do you have your comments, please?
Yeah. Yes. No. I think it's a very good discussion which is happening. Although Arun has raised the hand, but I'll just take have some couple of questions. So continuing with this discussion, has anybody looked at whether the relapse post CAR-T are aggressive or they are the same?
So not many large enough studies have yet been done. Most of the post-CAR-T relapses that we have looked at and few others have are using single cell, looking at the immune component, which is very separate consideration. The main thing we have observed, both post-CAR-T, BCMA CAR-T, and little bit post-GPRC 5D CAR-T, a little bit more GPRC 5D bispecific, but there have been studies. And the focus has been, and what is observed is not about the mutational burden, because one of the concern ends up being the conditioning or lymphodepletion with fludarabine is not very kind to genome, and it definitely causes more mutation. So we don't know that exact answer yet because we need a little bit larger studies. However, enrichment of the clones, most likely, not creation of a new clone, but it could be either losing either BCMA and or even more so GPRC 5D is more frequent than we think. So we had one paper, and my other colleague, German colleague, had one paper, and then there are a few others of losing BCMA on both the arms. We have a paper that will come out in Blood Advances in next couple of weeks, showing that around 8 to 9% of all myeloma has loss of 16p. So 16p is where BCMA is. So there are a little less than 10% of the patient already has one loss of BCMA. What I don't know, to answer your question specifically, do those 10% patients, or are they at greater risk of losing the second one and becoming BCMA negative, for example? We don't know that. Number two, we still don't know with the smaller studies we have whether fludarabine is causing more mutation. Fludarabine is definitely causing stem cell damage, but we don't know the mutation. And third thing, Hari, to expand on your question, what was not in this paper, post-transplant relapses, is what is melphalan doing to the bone marrow in general? The non-myeloma component, are we seeing more mutations in stem cells or myeloid component? We don't know that answer to that yet. And that may be true too. There is still no sense, and I have a very good younger colleague who focuses on CHIP in myeloma for myeloid thing, and there's still clearly no clear sense that transplant increases or enriches the CHIP clone, at least at the moment. And there's an ongoing studies with our French colleague to see what happens. But we don't have a good answer yet about what does CAR-T do to this. The question is very complex, Pankaj. So yes, this was easy, not easy, but it was good to publish what we did with increased mutation. But a fundamental question we are looking now is it per cell mutation increased? So each cell having 5,000 mutation, now they are 7,000? Or there are more clones with various number of mutations. So when you do bulk sequencing, you end up with higher number of mutations, or maybe both. And each has a different nuance about how we may approach it in future to benefit from it or counteract it. And so this study opens up that question that we are now looking at using single cell whole genome sequencing to see how many clones are there and how many mutations per clones are there. So it's kind of complicated story, but it'll lead to a good practical application.
Yeah, the reason why I asked this question is because that will also determine whether we want to put CAR-T as upfront therapy, using as first, second line or as fifth, sixth line. So that will also answer that. And that also brings down a question that, if the responses with CAR-T cells are same, whether you use upfront or whether after sixth line. So that means the T cells which are there in myeloma, whether you use after the first line, second line, what happens to those T cells? That means those remains the same where you are actually making the CAR-T?
No, that's a very, very good question, Pankaj, and it's at the top of list of things to be answered or solved. What is the health of T cell when you correct it at the second line or first line versus sixth line? And there is reasonably good data accumulated, most of it is not yet published, that later collection of T cell does decrease or does impact the T cell fidelity, T cell health, and you might see earlier exhaustion versus not. So there is an ongoing discussion within the academic groups, but also with companies, whether there is a theoretical possibility of collecting T cell right after induction, and not very practical because it requires a lot of coordination. But exactly to your question, it will be an important component, and we do know from our own studies that the T cell after one or two line are healthier and better compared to T cells later. And the complexity is just looking at the phenotype may not be enough. We need functional T cell measures. And then we are going back to some of the older ways we used to study T cells, etc. But we will need to keep that in mind in deciding where we do and how we do it, because the collection, Paris's product definitely impacts the card product.
Right. So my last question is actually related to indirectly related to this journal. You mentioned about the consensus documents. So one of the thing is when we say 1Q is heterogeneous, even 414 or even 1416 all behave heterogeneous. So whether it is the presence of hyperdiploidy which is defining this prognosis, what is the role of hyperdiploidy in 1Q and in all these risk stratification?
So hyperdiploid is a unique group, and most of the 1Q and the translocations are, I wouldn't say totally mutually exclusive, but they are not seen in hyperdeployed. Look at the hyperdeployed. We had a paper, and Mehmet, who is the first author of the paper we just talked about, the mutational burden post-transplant. He's the first author of that paper too, and it says chronology of copy number changes in myeloma. And if you see the very first figure there, they are half and half. 54% are hyperdeployed, 46 are not. But then the changes we are talking, 414 and or 1Q, they all come from the second group, and very few are shared with hyperdeployed. So patient has hyperdeployed, they are considered good risk and out of the risk stratification. If they do have 1Q, I think we need to look at it. But the new definition is also going to be that 414, 14, 16, 14, 20 by themselves are also not going to be considered high risk. It's only when they're connected with 1Q or 1P is that they become high risk. So I think overlap between translocation and 1Q, 1P is going to be important, but with hyperdeployed, it's not going to be considered important.
Right. Thank you. I think Arun has a question.
Yeah, so my concern was with the PFS curves, which was actually flashed. If you see the first 3 months, in fact, you would see that the CAR-T arm actually does a lot worse. And if the authors actually had submitted that the bridging therapy which was used was not matched, although the same VPD and the DARA-PT was used in both the arms, although the doses were slightly different. So do you think is it to do with one, the disease aggressiveness which played a part, and that made some of some patients who are waiting for CAR-T progress and die? Or is it to do with like what Pankaj was alluding, our tumor T-cell exhaustion which played a part? And do we have any light in the tunnel? Like, do we know what should be a good bridging therapy when people wait for CAR T-cell therapy in myeloma?
Yeah, so me, I would not think that in a randomized study like this, there would be difference between, and I was not able to hear you exactly very well. So if I'm not answering your question, interrupt me or tell me. But there was too much echo somehow on my side. But because it was a randomized study, I cannot think or believe that aggressiveness of the disease in the CAR-T group impacted the outcome in this patient population. It was the physician's choice. These are early patients, so they have probably many good choices. And in that regards, this initial, I would say around 5% or so early mortality is intriguing. I do not think it fits within the CAR-T related complications. And basically, they are saying that bridging phase patients in cilta-cel arm were receiving the same treatment as the standard of care. So they all got the very similar treatment. So it has to be something. And day zero was when patients got the CAR-T, when the patients got the CAR-T cells. And the bar is when they finished it, right? Annie, can you correct me with that?
Yes, sir.
So they said they were the incidence of early death occurred before infusion of cilta-cel.
Yes,
And
it was before.
Yeah, so that remains sort of intriguing. Why should it be different? I do not know. Patients were truly, and this is a very standard done study, good quality study. There was no selection of patients who would go on CAR-T because they are serious. You know, we have all had that in the CAR-T1 or KarMMa-1 study, more serious patients, because it's not a randomized, we would try and see if they can get CAR-T. This was early days when CAR-Ts were not available. So patients ends up being more serious when they go on CAR-T. This is randomized. I don't think the death before the line that you see in the figure, which is before infusion of CAR-T, can be truly explained by more aggressive patient. It could be chance, but this is reasonable number, 5% or so. So it's not a small number. So I don't have a good answer why. So there are 8 patients who died in that group. No, 22 and 8.
Yes, it was a very large number, 22 versus 8. So that was what I was wondering, whether a bridging therapy optimization before we take up for CART would have made a difference in such patients.
Yeah, so I think you raise a very important question in a direct or indirect way, which is that for CAR-T to be safe and CAR-T to be effective, I personally believe that a very good earlier cytoreduction will play a very important role. In the early days, 3-4 years ago, 5 years ago, we had this bias that you need myeloma for CAR-T to get activated and then function well. Not true. Even a small myeloma burden is good enough for CAR-T to work better, and it's beginning to look like smaller the burden, it might do a better job. So you are very correct that before taking patient to CAR-T in real life, where we are not in a study, we can do whatever we want, we need to try to cytoreduce as well as we can, and then we will have less CRS or less degree of CRS, and also possibly higher response. There was one of the KARMA study, I think it's KARMA 3. No, not 3. One of the KARMA study which looked at that question of initial induction followed by CAR-T, not published yet. And the data clearly showed that a good cytoreduction gave rise to a very good response in the end, higher response rate and safer treatment. So you are very right. This is intriguing. Why the early death rate? But if it is just disease progression, again, an important question would be which countries, which places these patients came from. Would a solution be what your suggestion was, which is to have a good cytoreduction before they go on treatment? In the study, you cannot do it, so we will have to live with it. And 22 and 8 might be significant difference, statistically speaking. I don't know. I haven't done statistics on that, but 10% versus 3 or 4% could be different, significant difference.
Thank you, sir. Thank you.
There are some questions in the chat box also. I think, Hari, you can mention those.
I didn't see it. Okay, I saw it. How we tackle the disease of multiple myeloma is one question, and role of BCMA deletion in testing, if significant, it is routinely done or in selected cases on the basis of sequencing. I think the myeloma question is a little too broad, how to tackle the disease. I think we can have a whole day, and maybe in January we will have a whole day to discuss it. So I would respectfully pass that question. But the second question is important. Do we test for BCMA or should we test for BCMA? So as part of this risk stratification, redefining the risk in myeloma, one of the recommendations that is going to come out from our consensus is going to be that we need to move towards more sequencing-based analysis rather than patient cytogenetics. It won't be recommended overnight because everybody has to get used to it. Expense-wise, they are similar, supposedly similar, but there are many issues. The reason I bring it up is that because we have multiple BCMA-targeted treatment, before utilizing the first BCMA-targeted treatment, I don't think you need to look for it. However, if a patient is getting a second BCMA-targeted treatment or third, then there is some rationale to look for it because we have patients who have relapsed with reasonably good number of circulating CAR T cells. And we, on a research side, we measure routinely CAR T cell for months and years. They are circulating CAR T cells of really good proportion, 5%, 10%, and they are relapsing. So what would it be? Obviously, it would be BCMA loss and or some such BCMA cell surface expression impact. So we are beginning to all think that that should be done routinely. The problem is that the BCMA antibody is not very good. Even in US, we do not have a very good standardized BCMA measurement. Even the companies who's making all this money on this, they don't have a good companion diagnostic for BCMA yet. So I think there is a need for it, and because of the need, there will be development. But I would, for second BCMA, so if somebody got BCMA CAR T cell and relapse, for him to get a bispecific, I would want to make sure the cells are BCMA before I give it. And there's that expensive treatment. Or if somebody did get in old days belantamab, and then they're getting something, I would want to be sure before somebody spends so much money before you do it. And number two, because the sequencing end or FISH are easy, if the protein measurements are not yet available, one can think of, if available, if feasible, to look and see at least the BCMA locus is there or not. Not as informative because locus may be there, but BCMA may not be expressed. But I think we are inching towards need to do BCMA, need to do GPRC5D. Most of our newer targeted panel includes this. So at least we know the DNA part, protein is separate. And there's one more question. Any update on the role of MRD testing in myeloma in 23? I think the update is that, again, that's another topic that requires half a day for discussion, except it is becoming more and more standard in our practice. And methodology are reasonably standardized. Flow or sequencing, either are fine, whatever is available or accessible, except to make sure, and I would really put this in capital, that whatever method is used is validated and has at least 10 to minus 5 sensitivity. 4 is not good enough, but it could say we don't have anything. 4 is all we have. That's better than nothing. But so doing MRD testing with really not very good sensitivity or a standardized test is counterproductive, because you would make a decision on that. A patient comes and says, should I get a transplant or not? And he is MRD negative after induction and is not so willing, I'll be comfortable saying, yeah, we can postpone, and we collect the cell and postpone. On the other hand, if he's positive, I said, you have high risk disease, you need to move on to getting MRD negativity and proceed. So I think this is just one example. A lot of decisions are made based on this. So I think this is becoming standard. All our patients routinely and almost everyone gets MRD testing.
Hari, you are not audible.
Not yet.
Not, not audible. I think we can go to the next phase.
Yes. We'll move ahead. Nirav, can I have my slides, please? So we have our journal scan presentation here. And actually what happens in that, I will cover briefly. Nirav, can you upload my slides, please?
Hello. Just a second, sir.
Yeah, thank you.
Yeah, so can you hear me now? Sorry.
Yes, sir.
Yeah.
Now we can hear you. Yes.
Yeah, okay, there's some problem with my, okay.
Shall I go ahead, sir?
Yeah, please.
Yeah, please, Arun, please. Yeah.
So, like as alluded to by the international expert here, the journal scan actually discusses briefly about a topic which was recently published, and in fact, this topic, the verdict has been out. It was lucidly discussed by Nikhil that how high-dose melphalan treatment during an autologous transplant can affect mutational burden and may or may not affect the outcome. I think the verdict is clear. But let's hear it out from the person who wrote the best commentary for this article. We had actually 12 entries for this. So next slide, Nirav. So how do we start the entire process is we actually choose an article. The expert helped us choose one of the finest articles which was recently published. An invite is sent on mail to many of our residents and all myeloma connoisseurs, I would say. And anyone can participate who actually has an interest in myeloma. We expect a commentary to reach us in time, and we have a panel of blinded reviewers who chooses the best commentary, and we give a 5 to 8 minute slot for the presentation as a pre-recorded audio. What you gain from this is you can present it in front of an august audience, and you have a certificate to earn and definitely vouchers worth 5,000. So the next slide. So what actually is the purpose is, like, you come across the latest on plasma cell displays here. You have an art to critically appraise the article, you improve upon your art of scanning them. And in fact, some of us can actually write letters to editors as well on this. And definitely for some of us that becomes a matter of interinstitutional prestige. And we have TMC and Tata neck to neck. They have been winning it on and off in the last few editions. So how do we analyze? The next slide is importantly, we cover up these 8 variables and we choose out of the best entries we have. And we always try to tell you to stick to the word limit and dwell on the statistics and methodology as well. That is what we use to choose the best entry. So for this month, the best commentary has come from Dr. Shashwata. He is actually no stranger for us. He has won it another time here. So he's an ad hoc assistant professor from Tata, and as assistant prof, and maybe just being assistant prof, he can be quite busy, but he has been sending us commentaries and being very critical with his appraisals. So with that, I would request Nirav to play his pre-recorded audio on the topic.
Good afternoon, respected teachers and my dear colleagues. First of all, I would like to thank Team Image for giving me this opportunity. Today in Journal Scan, we will discuss high-dose melphalan treatment significantly increases mutational burden at relapse in multiple myeloma. This article was published in Blood Journal on 6th of April 2023. The beneficial role of high-dose melphalan with autologous stem cell transplantation has been demonstrated in newly diagnosed patients with multiple myeloma in a number of prior studies. However, the impact of high-dose melphalan on surviving multiple myeloma cells is not well characterized. Melphalan, an alkylating agent, inhibits DNA and RNA synthesis by chemically altering the guanine bases in DNA. The unintentional repair of chemically induced mutations can eventually impact the mutational load on tumor cells. The aim of the study was to investigate the possible DNA damaging effects of alkylating agent on multiple myeloma cells following high-dose melphalan. The study included all patient samples that were collected from IFM DFCI 2009 clinical trial, which had RVD arm and RVD plus HDM and ASCT arm. Bone marrow samples were collected at the time of diagnosis and at the time of relapse. All tumor and constitutional DNA samples were profiled using whole genome sequencing. Flow cells were prepared and sequencing clusters were generated according to the Illumina protocol. Deep whole genome sequencing on CD138 positive multiple myeloma cells from 138 samples collected from 68 patients at the time of diagnosis and at the time of first relapse. Among the 68 patients, 25 patients were from the high-dose melphalan arm and 43 patients were from the RVD arm. As seen from the table, there were no significant differences between the age, sex, ISS, cytogenetics, best response, and the time to progress. So at relapse, significantly higher increase in SNBs were observed following HDM compared to RVD alone. There were also corresponding increases in the overall mutational load, which was 73% for HDM versus 24% for RVD. Of all the detected mutations, 45% were observed only at relapse for HDM group compared to 34% for RVD group. There were no changes in the deletions, duplications, inversions, translocation, or copy number changes. So all translocation involving immunoglobulin heavy chain were observed at diagnosis and maintained at relapse. There were no differences in the driver mutation and the rate of accumulation of mutations was significantly higher in HDM group versus RBD group. Patients treated with high-dose melphalan accumulated significantly more mutations within the regions between transcription start and transcription termination sites. Multiple myeloma signature 2 and multiple myeloma relapse signature 5 had a significantly higher relative and absolute contribution. Similarly, multiple myeloma ID signature 3, which was associated with repair of DNA double strand breaks by non-homologous end joining, had significantly higher relative and absolute contributions for patients treated with high-dose melphalan. At the time of relapse, the majority of the mutational load observed following high-dose melphalan was at subclonal level, and significantly higher heterogeneity was observed in high-dose melphalan cohort. Mutations with less than 50% of cancer cell fraction were more common in the high-dose melphalan arm. Mutational load at relapse in high-dose melphalan increased greater in patients achieving CR compared to others. However, there were no differences in the survival according to the mutational load or whether they could achieve a CR or not. A significantly higher number of neoantigens were seen in patients relapsing following in high-dose melphalan compared to RVD alone. So the mutational burden was significantly higher following high-dose melphalan compared to RVD. The lack of changes in large-scale events and significant increase in point mutation suggests dysfunction of specific DNA repair pathways. The current study and all other available datasets do not indicate the post-transplant relapses have a worse outcome. So the study has few limitations. The study was conducted in a small subset of IFM 2009 patients. The study could not evaluate the impact on myeloid cells or stem cells after HDM exposure. Possible treatment strategies to overcome the mutational impact is not addressed. The study provides initial data to generate hypotheses regarding possible immunotherapeutic intervention post-transplantation, and future experimental validation studies are needed. Analysis using deeper response assessment such as MRD should be considered in the future. It may highlight the true impact of mutational increase following deep responses. Thank you.
Thank you, Neerav. I think the Dr. Sahab beautifully summed it up to tell us that the transplant is going to stay. High-dose melphalan will have its place. The concern probably about mutational burden does exist, but mostly they're subclonal and would not affect outcomes in the follow-up we have. The neoantigen should come to our rescue and maybe enable more epitopes to be unleashed, and maybe we have immunotherapy also up our back to help us reap the benefits of a transplant subsequently. If there is a closing remark on this from Dr. Nikhil, I would invite that, because customarily we don't have a discussion on this. So because he's an author of the paper, I would want to hear it out from him if you have anything to add beyond this. So.
I just have one comment. It was very beautifully presented and very well discussed. So very good job.
Thank you, sir. Neerav, can I have my slides back? We move to the last segment. That's a very small segment of quest, which actually reiterates what we learned in the last 40 minutes or so. Apart from the first question on the trivia, the others are based on the journal club and the journal scan we present. The rules of engagement have been discussed, so I would skip that. So we move to the first question here. So I want you to go through the options given here and tell me what intervention is being done in this myeloma patient. You can see the cartoon here, and you have to choose the best of the 4 options given. We move to the next 2 questions that will be on the journal club, that is the CARTITUDE-4 trial. Most of us who have myeloma connoisseurs would want to go on to the details of what the trial is all about. So this is about the inclusion criteria. So I want to pick, you to pick up which of the following was not an inclusion criteria in the CARTITUDE-4 trial. The second question on the CARTITUDE trial would be based on the trial design and sample size calculation, because before making any meaningful conclusions, we must be very critical about how the sample size was calculated and the study was designed. So please choose the incorrect statement out of the 4. The last 2 questions on the journal scan, that was about the impact of high-dose melphalan on mutational burden at relapse in myeloma. So you need to tell me which is the incorrect of the statement with respect to the findings of this trial by Samor et al. We'll briefly discuss the answers in the end before we wind up. And the last question for the day is again with respect to the findings of this trial, which studied the impact of high-dose melphalan on the mutational burden. If you are closely following up the journal scan presentation, it's an easy pick for you. And most of these are take-home messages from the study. Thank you, Nirav. I'll just move on to discuss the answers while a coordinator compiles the results and announce the winner's name. So the first question was about this image, and you should know that this is a procedure where a balloon is first inserted into a fractured bone, and then you create a cavity and space and you do cement augmentation. So technically, it is correctly labeled as kyphoplasty and not vertebroplasty, where we inject a cement mixture into the fractured bone through a hollow needle. The other two were options were irrelevant. The next question was about the inclusion criteria in the Cartitude 4 trial. You were supposed to choose the incorrect inclusion criteria. So, of course, the statement D, subjects with one prior line of therapy must have progressed within 48 months of a stem cell transplant. If not transplanted, then within 60 months of starting therapy. So that was the incorrect response. The next question was about the sample size calculations and the study design. All the three statements, A, B, C, were correct. But what was incorrect was the final analysis was to be performed after approximately 250 events were accrued and not 150. It's important that like the study is reporting an interim endpoint, or are we actually having the final outcome analysis when we discuss the trial to be known. The next two questions were on the journal scan, and these were like take-home messages which were reiterated that the mutation was a subclonal, the mutation burden was higher, and what was interesting to note that neither patients with high mutational load after melphalan nor patients who achieved CR at significantly different survival rates after PFS1. And coming to the last question, again alluded to by the presenter that these translocations, which were seen ab initio and had involved immunoglobulin heavy chain, were conserved at relapse. So if you had a T414, a diagnosis at relapse, the results were concordant and not discordant. The other three statements were correct. With that, we come to the end. Nirav, can you share the name of the winner of the day?
So it is Dr. Aditya Jindal from Homi Baba Cancer Institute.
Oh, Dr. Aditya Jindal, he is an alumnus of the PGI and must have recently joined the Homi Baba Cancer Institute. Congratulations, Dr. Aditya. What awaits you is a certificate voucher for you. Thanks for joining us. With that, I must invite you for the next month's Journal Club as well. We meet up now every fourth Thursday of a month. It's going to be 28th of September of 23, and we will have Dr. Nupur Raje coming back to us and helping us out solve the mystery of some of the trials which have been published. A gratitude to all my scientific newsletter subcommittee members, Dr. Das, Dr. Joseph John, Dr. Hari Menon, and the constant support and the guidance we receive from this eminent faculty from our national arena. And last but not the least, the gratitude to Dr. Nikhil Munshi, who, despite his busy schedule, agreed to choose the article for us, all the two articles, spend a lot of time critically dissecting it out and beautifully explaining it, how to go into the nitty-gritties of trial and interpret the trial data. Thank you, sir. With that, I hand over the webinar to Dr. Hari Menon for his concluding remarks.
Yeah. Can you hear me? So my
yes, sir. Yes, sir.
Yeah. Okay. Because it's got a mind of its own. I think.
Hari. Before you make a conclusion remark, I just want to be cautious that next month on 28th IMS will be going on. So I hope we will confirm again from Dr. Nupur whether she is free at that particular time to supervise the Jana Club or not. So
I was going to mention that's right in the middle of day 2 of the meeting. I think it's Thursday. So it would be around 2 o'clock, and I don't think but yeah, please do, because that would be right in the middle from Athens.
yeah, over to Hari.
Yeah. Thank you. Thank you. I'm sure all of us would agree that we had a wonderful session, and thank you, Dr. Nikhil, for making that that much special with your wise inputs and knowledge on the subject. And thanks to my colleagues for their inputs too on the meeting, and thanks to the presenters, Dr. Annie, and our colleague from Tata Memorial who made their presentation, a wonderful gist of the presentation. And we always look forward to the meeting every month, and every time we are richer for the experience. Thank you once again, and have a good day.
Thank you so much. Thank you so much.
Thank you.
Yes.
Thank you.
Have a good day. Bye.
Good day.
Bye.